Hello, everybody. We'd like to acknowledge our loyal listeners as we wrap up 2025 and our Professor podcast. If not for you, we wouldn't be here doing this job we love.
That's true.
That is true. A couple weeks ago, we did ask you to send in your questions regarding maternal child health, if you will. And we have gathered questions from all over the country,
All over.
all over
Every
the
state.
country. And we thought we would just acknowledge our listeners, as I said, loyal listeners. Without you, we would be nowhere. And spread the good word through answering those questions.
Yeah. So thank you to all of you.
And to our wonderful sponsors as well.
Yeah. Throughout the whole semester. They've been great.
Absolutely.
Thank you.
So why don't we just get started? And we're going to answer the questions together. I'm just going to take charge and actually
Read them.
acknowledge the listener and read the questions that they have for us,
Okay.
if that's all right.
Yeah.
Madison from New York City
Oh,
writes to
Madison.
us saying, I am trying to get pregnant. Well, good luck to you, Madison. How will I know I'm pregnant? Are there any signs I should expect that can indicate I'm pregnant? What would you have to say to Madison from New York City?
So Madison, good luck on this journey. Fingers crossed, everything works out well.
Absolutely.
So to start off, probably the more common presumptive signs that you might see is you might have a missed period. That's really common. Or breast tenderness, I would say too. Some people might have a little bit of morning sickness too in the beginning before they get to confirm that pregnancy. Some people,
Fatigue.
fatigue too, very tired. Some people will also do a pregnancy test at home, but that's a probable sign. That doesn't mean you were definitely pregnant. Usually, some cramping or a positive pregnancy sign, even though it's a good indication you are, that's probable. So to know for sure you're are actually pregnant, positive signs are you're going to need that ultrasound, auscultating that fetal heart rate. So we want to hear the baby's heart rate on that ultrasound as well.
So you're saying a pregnancy test is not a positive sign?
It's not a positive sign. So a positive pregnancy test is not a positive sign. It's a probable sign. So you are probably pregnant, but we need to confirm with that ultrasound.
All right. So presumptive are those things, the subjective stuff that so that Madison is going to be feeling, but nobody else can see or touch to.
She's the only one.
And then probable are more outward signs, more objective signs, but doesn't necessarily mean 100% pregnant.
Yeah, so positive pregnancy test, sometimes Braxton Hicks, which are like your uterus prepares, so like the cramping, false contractions.
And then positive sign of pregnancy are those that can't be anything else. Those are that's the diagnosis.
Yeah. So actual fetal movement, but that's usually after like 20 weeks. So usually it's going to be that ultrasound to confirm you're pregnant, hearing that baby's heartbeat.
That's neat. All right, Madison, good luck to you.
Yes, good luck.
From all of us here at the Professor Podcast. Now, Imani from Atlanta, Georgia, she says she's in her second trimester. Well, welcome to my favorite trimester, Imani. Anyway, she's in her second trimester, and the doctors are always measuring my stomach with a measuring tape. What are they looking for?
All right. So what they're doing is they're checking your fundal height. So usually after like 20 weeks, a lot of the providers, when you go in for a prenatal visit, will just be measuring your fundal height. Usually the fundal height in centimeters is equivalent to how many weeks pregnant you are, your gestational age. And so that's what we're checking for. We want to make sure that in centimeters, it's equivalent to how many weeks you are truly pregnant. And we also want to check the growth, that are you increasing every week? Is that a steady rate that makes sense?
So it's a very low tech screening approach to expected growth.
Yeah, that's it.
All right, Imani, that's what they're doing. They're if they followed up that measurement with scheduling you for an ultrasound, that means that in centimeters from your pelvic bone to your fundus, which is the top of your uterus, is more than 2 centimeters off what your gestational age is. So if you're 24 weeks and you're measuring 28 weeks, they probably send you for an ultrasound saying, is there too much amniotic fluid? Is the baby getting too big? What else is going on?
Yeah.
So low tech approach to expected growth. That's neat. Thank you, Imani, and good luck to you in the rest of your pregnancy. Now, Gianna from Chicago, Illinois, she is also pregnant with her fourth. And the doctor said I may need to take some extra medications in this pregnancy to prevent complications like my last two pregnancies.
Okay.
She went into labor with her third at 28 weeks. And she had preeclampsia with her second.
Okay.
What medications are the providers talking about?
Okay, so Gianna, thanks for calling in or sending us the question. So hopefully you're already taking your prenatal vitamin to help prevent those neural tube defects. That's the one medication definitely every pregnant woman should take for folic acid. Yep. But extra medication you might need based on like your previous pregnancies and just to prevent any complications in this pregnancy. One might be baby aspirin. Sometimes we start this before the 16th week, or even earlier, depending on the provider, just to prevent preeclampsia, especially if you've had that history or you're at increased risk of developing preeclampsia. And then the other thing might be progesterone injections if you've had a history of preterm labor to help prevent that, get you to term.
Right. So baby aspirin, some progesterone, possibly. Gonna take care of preeclampsia and preterm labor. Cool. Yeah. Good luck, Gianna. I hope your fourth pregnancy goes without a hitch. Now, Ruth from Salt Lake City.
I didn't like that question. Don't make fun of me. I could read Ruth's question if you just.
Go ahead. Good old Ruth.
Ruth. All right, Ruth. As I approach my due date, I'm becoming more uncomfortable with my pregnancy. I have pelvic pressure. Well, that's expected. I'm peeing every hour, especially at night. Ooh, that's just being a woman. And sometimes I find I am short of breath, just like Professor Lopes. Is there anything you could recommend for these discomforts?
Well, when it comes to like pain during pregnancy, the only thing really recommended, if at all, is Tylenol. You can't take Motrin when you're pregnant.
Yeah.
Or Advil or ibuprofen. Can't take that, but Tylenol can be taken for some discomfort. And I have to tell you, those other symptoms are because you're kind of running out of room in your trunk, if you will, right? Sitting more upright, especially when you're trying to, go, you might have to put a wedge in your bed a little bit just so that you're not laying flat. That might help with the shortness of breath when you're laying down. And the baby's head is, or the whatever presenting part is really pressing down on that bladder. The only thing recommended might be to you still need to drink a lot, but maybe if it's overnight, you're getting up and peeing a lot. Drinking more of the load of water earlier in the day might prevent some nighttime urination. But by all means, continue drinking plenty. It's all about just running out of room.
Yeah.
So,
I was pregnant with twins and I got all the way up to term and I had to sleep the last month upright in bed, literally sitting up because it was just so much like pressure and I was so short of breath. There was so much pressure on my chest that I was sleeping upright.
Short of breath, just thinking about it.
Yeah, it was tough. So, but sometimes that's what you got to do. So, sleeping upright, it'll be over soon. Just get to term, have a healthy baby. That's the goal.
Good luck to you, Ruth.
Yep.
Yeah. Now, Aaliyah from Detroit, Michigan. She says, I'm pregnant with my first, and the morning sickness is terrible. When should I expect to feel better? And when should I be concerned?
All right, Aaliyah. Well,
Mhm.
morning sickness, it happens to so many pregnant women.
Mhm.
It's common. Usually you're going to see that in that first trimester, but it can go up to the 20th week gestation.
Yeah.
So, the where you want to be concerned though is if you're losing a lot of weight, like 10 pounds in like 1, 2 weeks, right? That'd be something that's concerning. And you can't hold anything down. You're constantly vomiting. Um, that would be something where I'd want you to go see the provider or go to the hospital.
Mhm.
We need to monitor electrolytes just because you're losing a lot of fluid, you're losing a lot of weight. And sometimes you have to be admitted for IV fluid. So that would be where I would get concerned.
Mhm. Um, I tell my students all the time that it's not a Harry Potter spell, but hyperemesis gravidarum. Doesn't that sound kind of like a something somebody should be waving a wand at you with?
Yeah, fancy words.
Fancy words. That's exactly what excessive nausea and vomiting with either more than 5% weight loss or dehydration electrolyte imbalance um, is a result of.
Yeah. And you got to stay hydrated. We want to take care of that baby. So that's
Yeah,
why we
if
want
you
to see you at the
continue
hospital.
to have trouble, definitely contact your provider. There may be some medications or supplements that they can counsel you to take.
Yeah.
That's right. Good luck to you, Aaliyah. Now, Anika from Minneapolis, Minnesota. Welcome to our podcast. She says she's 32 weeks along and being monitored for preeclampsia.
Okay.
The provider said I will need to be admitted if my blood pressure continues to rise and if I develop severe features. What features should I be on the lookout for? Are there any serious complications that can occur from preeclampsia?
Okay.
Very
That's a
good
great
question.
question. Yeah.
Yeah.
So, preeclampsia, if there's usually you're going to see elevated blood pressures with proteinuria, so protein in the urine. That's
Mhm.
usually what we find. But when it's preeclampsia with severe features, some patients will report headaches, visual changes, so like blurry vision, spots in front of their eyes sometimes. And sometimes we have epigastric pain. So not contraction pain, but in the upper portion of our belly. So usually where that liver sits, because sometimes if we're looking at labs on our point as the nurses or as providers, you'll see that they have elevated liver enzymes. And so that could be an indication that you have preeclampsia with severe features. Sometimes too, I notice patients will have increased swelling. It's normal to get edema and swelling when you're pregnant, but sometimes the swelling is not just like in the lower extremities, it's in their face. So they get like these big puffy face. And so those would be the things I would be on the lookout for. With those features, you're increased risk of having a seizure, and that's why you're going to have to be admitted. A lot of times the providers will give you medication to help control that blood pressure, and then medication to help prevent that seizure. So what we usually give is labetalol for blood pressure management, and then mag sulfate to help prevent those seizures.
Magnesium sulfate, we call it the central nervous system depressant. So that's exactly, it's also smooth muscle relaxer, so it may actually decrease some blood pressure. That's just a side effect. We give it to our patients to prevent seizures. All right, we know that it's a pretty powerful drug, and what drug should we have on hand if we're giving magnesium sulfate?
Calcium gluconate.
Calcium, very good, Professor Lewis. Very good.
Study.
Yeah, oh, that's very good. Um, the thing about blood pressure is not only can a pregnant woman or even in the postpartum phase have a seizure, high blood pressure causes vasospasms. Vasospasms lead to decreased perfusion of whatever neurologically, kidneys, whatever end organ effect we're talking about. But in terms of the baby, and I don't mean to frighten you, Anika, but our main concern when it comes to the baby is the baby getting enough oxygen and enough perfusion to the placenta to continue developing properly. So they're definitely going to be doing those tests and not only watching you and your blood pressure and your symptoms, but your baby. And is your baby getting what it needs in the environment with that as a possible challenge?
Yeah. And so it's not just the seizures, but sometimes too patients with preeclampsia, this is something where your body is so heightened. And then it can lead to the seizures, but sometimes too, we can even have complications like HELP syndrome,
Oh,
which
yeah.
is hemolysis, elevated liver enzymes, and also low platelets. And so that's why we monitor your labs pretty frequently as well, or DIC. So those are more other complications that can occur. And so we want to prevent that. So that's why your provider told you if you develop any of these features, we want to admit you and probably put you on mag sulfate.
Yeah, the only way to resolve this condition is to
Have a
end the
baby.
pregnancy. Yeah, end the
Yeah,
pregnancy.
have a baby.
Have a baby. It's probably a nicer way
Yeah.
of putting it, but
So,
yeah. Good luck to you, Anika.
yeah.
And I look forward to hearing back from you. And we will welcome your follow-up to us, letting us know about the healthy outcome for you and your baby.
Yeah. Send us a picture. We love pictures.
Absolutely.
Holidays are coming up, so.
Now, Mei Ling, a loyal listener from San Francisco, California, writes, I'm 37 weeks pregnant with my first and went to the doctor's office today for having on and off contractions. She says, my provider did a vaginal exam and said they are just Braxton Hicks. How do I know they are not real labor contractions? Is there anything I can do to make them go away?
Okay, so that's really common, especially when you're pregnant with your first, just in general, when you're pregnant. Braxton Hicks happens. They're just not those real labor contractions that are gonna cause cervical change. So your provider did an exam to see if you were making cervical change. And so if your cervix isn't dilating, it's not thinning out, that's how you know they're Braxton Hicks. They're not real labor contractions, or true labor contractions. So I know it could be a little bit uncomfortable, a little bit confusing. Sometimes if you just rest, drink a lot of water, they usually will just go away, especially if they're on and off, which you mentioned. They probably are just Braxton Hicks.
Yeah, changing your activity. So if you're walking around a lot and you're feeling them, then rest. If you're resting and you feel them more often, get up and walk around. So changing activity, making sure that you are well hydrated.
Yeah, drink.
Those two main things
Drink water.
will
I said drink, but I want to be clear, drink water.
water. My provider, when I started contracting about 3 weeks early, said, well, go home and have a glass of wine. And I'm like, I don't have any wine. So don't do that.
Yeah, water.
Water. All right, Marisol from San Antonio, Texas. She says, my midwife says I have a complete placental previa and will need a C-section. What sign should I be on the lookout for to know when to call the provider or go to the hospital? Will my baby be okay?
All right. So, Marisol, it's a good thing your provider is planning to do a C-section because that's typical for complete previous.
Absolutely. Tell me remind me again what a previa is.
So your the complete placenta previa, the placenta is lying on the cervical opening, on the internal cervical opening.
Oh.
So you don't want to go into have a vaginal delivery because then that placenta is going to be right there, right? And the placenta is that baby's lifeline is usually right. And so it's providing all that nutrients, blood flow, right? So we don't want to do any vaginal deliveries, nothing in the vagina if you have a
no vaginal exams or anything.
No vaginal exams. Yeah. So it's a good thing that they've already let you know that you're going to have a C-section. That's the best plan. Usually things that I would be on the lookout for would be vaginal bleeding. A lot of times with the preview, you could still go to term, you could still have a healthy delivery, healthy pregnancy. But if you notice that you have like this increase, like bright red vaginal bleeding, that would
with
be
no
something.
pain.
Yeah, with no pain. Yeah. If you have like pain and your uterus is really hard, that could be an abruption. So we don't want that. Whereas a previa, that bleeding, painless, your uterus is still soft, that would be something to go in and be seen. Excuse me.
So we definitely do not want the cervix to open up. Your provider may schedule your C-section for a couple of weeks before your due date because they don't want you to be out of the grocery store when your cervix starts to change.
Yeah.
Because that that placenta is rich with blood supply, and we don't want you to have any excessive bleeding.
Yeah, but your baby, you could still, have a healthy pregnancy. Your baby, usually, there's no issues with the the fetus. The fetal heart rate is normal throughout the pregnancy and everything too. So,
That's good to know, Marisol. Good luck to you. And again, send us pictures when you deliver your healthy baby by C-section. Now, Sylvie from New Orleans, Louisiana. She says, I'm pregnant with my first and being induced for post dates at 41 weeks. Can you tell me what the postpartum period will look like?
okay, yeah.
Good question, Sylvie.
So there's a few things that the nurses are going to be looking at. We'll be checking in on your bleeding, your belly, a lot of frequent assessments. And some of the things we're going to look at, one thing we look at is breast. We want to make sure that they're soft, they're not too painful. It takes a few days for the milk to come in. Usually you have colostrum, which we call our liquid gold in the first few days, usually 1 to 3 days. And usually then as your milk comes in, that's when your breast might be a little bit more tender. We expect that, but we don't want to see any bleeding, cracked nipples. That's something where we would get concerned. So any like bleeding, discharge, that would be concerning.
From your breast.
From your breast.
Yeah, okay. Well, I've seen some pretty sore looking nipples.
Yeah.
So we got to make sure the latch is good
Yeah.
and everything.
Yeah.
Mm.
And then
It increases the risk of infection when there's a skin integrity issue on those nipples too.
True.
Yeah.
Yep. And then one of the things that we check for, it's kind of uncomfortable for the patient. So I apologize in advance. But we will be pushing down on your belly. We push to look for the fundus, which is the top part of the uterus. So we want it to be nice and hard. Okay. We call that firm. A uterus that is soft, we consider boggy, and that can indicate a postpartum hemorrhage, which we don't want. So that is something we're going to be checking for. And we will prioritize as nurses. Once you deliver, we're going to be checking that fundus. That's our number one priority. Check that fundus. Massage the fundus.
Yeah, I'm be looking at that a lot.
Yeah. And then other things we look for.
Can I just ask a question first about fungi? Would it be fungi, you think? For plural of funduses?
I don't know. Most patients have one, so.
All right, well, we'll go with that. With the fundus, where are you I mean, so it's in the belly, obviously.
Yeah.
Say a patient delivered this morning.
Yeah.
All right, it's 2 o'clock in the afternoon. So within 12 hours of birth, where would you expect to find that fundus?
Yeah, so usually it's at the umbilicus, your belly button.
Okay.
Okay. Usually that's where we find it.
Right in the middle?
Right in the middle here. Right? Everybody got to think like where your pelvis sits, right? It's midline to your body. So that's where ideally it should be. Okay. And it goes down about 1 centimeter every day, every 24 hours or so. That's typical, could be a little bit more, but usually it's 1 centimeter a day. It goes down. And that's what we're checking for, that your uterus is going down every single day in normal progression.
Okay. Cool.
That makes sense?
It does to me.
All right. And then some other stuff we look for is your bleeding. So you're going to have, excuse me.
All about the lochia.
Lochia. You're going to have vaginal bleeding. We call it lochia. It should be like a darker red the first few days. Usually day 4 to 10, it could become like a pinkish brown color. And after 10 days, it could be like a yellow whitish color. It should have no odor. A fleshy odor is normal, but it shouldn't be something that's concerning for an infection.
Yeah.
And we also want to make sure that there's not big clots. Heavy clots, a lot of clots, those would be things that we would also be concerned for in terms of hemorrhage.
So like a heavy period is perfectly reasonable, but saturating a pad within an hour, that's not reasonable.
Yeah, I mean, I've had patients saturate pads like every 15 minutes, right? Yeah. That's concerning.
That's too much. That's too much. So basically as your recovery progresses, the bleeding gets lighter in color and amount, basically.
Yeah.
And it goes in that direction. But if you're increasing your activity and let your bleeding be your guide. If all of a sudden you're bleeding more than you were and it got darker versus lighter, That's your body saying, time out, you're doing too much. So it should be progressing into the lighter phases, not going in the other
Yeah.
direction.
Especially for like a vaginal delivery, you might have a little bit more heavier bleeding after delivery. C-sections sometimes are a little bit lighter, but
Mhm.
yeah, should get less every single day.
And we're asking you to get up and check that frequently. You're gonna have to anyways, because one thing that women who have had babies report is that they are going to the bathroom, urinating very frequently. That's your body getting rid of all the extra fluid it doesn't need anymore because it's not pregnant. Lots and lots of bleeding. I mean, lots and lots of voiding, lots of
Yeah.
urine. Um, we call that postpartum diuresis in our world, but for patients, it's just in the absence of any other symptoms, perfectly reasonable. That's your body getting rid of extra fluids.
Yeah, and it's normal too, like it to go to the bathroom so
Mhm.
frequently, but keep that in mind too. If you're not, that could be a concern because if your bladder's too full, it can actually displace your uterus off to the side, or even higher, and that can also lead to a hemorrhage. And so we want to make sure you're emptying your bladder frequently. And if it's something after delivery you find you can't do, you don't feel like you have to go, maybe you're still numb, if you choose to get any form of anesthesia, that's something where your nurse can always insert an indwelling catheter or intermittent catheter just to empty your bladder, depending on where you are in your recovery.
Mm-hmm. Pushed around uterus, might bleed on you.
Yeah.
My students will know about that.
Yeah. And then other stuff we look for is we look at the perineum or to see if you had any form of perineal laceration or an episiotomy if the doctors had to do a little cut. Sometimes they have to do that just to get the baby out. And so we're just looking, usually that gets sutured. Sometimes people get worried about that. They're dissolvable stitches, usually within like 10 to 14 days, they dissolve on their own, nothing to worry about. But we do check to make sure they're well approximated and the area is healing.
We go through what we call the bubble assessment, right? Bubble.
Mm-hmm.
So we pretty much just talked about that, right? Breast, uterus or fundus, bleeding, bowels, bladder, lochia. I guess that's not bleeding is not a B.
Yeah.
Episiotomy or that area, edema, emotional. That's the other thing that we probably should mention, which I think another caller has asked about it as well. But the postpartum blues and postpartum depression. Well, I guess we'll talk about that in a little bit.
Yeah.
But know that hormones shift and there can be a normal amount of kind of teariness as a result of fatigue and some hormone shifts that you may also expect. We'll talk about it. We'll talk about that a little bit more down the line.
Yeah. And the other thing too is like something else, just so you kind of know what to expect. You had a baby pushing on your organs. So sometimes it takes a while to have a bowel movement.
Mm.
This is like one place where like you can actually leave the hospital without pooping. It's okay. But what we want to make sure is you have bowel sounds and gas. And that's why I definitely want to encourage getting up. The earlier you get up to ambulate, the better, right? It moves things around. We want you passing gas. Drinking fluids, staying hydrated too is really important.
Absolutely.
Yeah. And then, for just some of the discomfort, don't be afraid to take some pain medication. Tylenol, ibuprofen, they really help. Let your nurse know if you're uncomfortable. And then ice packs and witch hazel or even dermaplast spray. Those are really things if you have any like perineal discomfort. Yeah. If you have some like perineal discomfort or you're swollen, especially the first 24 hours after delivery, definitely consider that stuff too.
Fit on that.
Just keep those things in mind.
That's
All right,
great.
but we wish you luck.
Absolutely. Now Harper from Seattle, Washington says she's scheduled to have a primary C-section for her baby's breech. And she's going in 2 weeks for that primary C-section. She did have a vaginal delivery with her first baby. Can you explain how the postpartum care will be different and what I should expect? And will I still be able to exclusively breastfeed?
Yeah.
Great questions, Harper.
Great question. So, pretty similar to the vaginal delivery, we're still gonna check your breast, your fundus, which is looking at the uterus and where it is. Is it going down? Is it in the right location? We're going to look at your bleeding. A little bit different though, instead of looking for like a perineal laceration or episiotomy, we're looking at your incision. Usually wherever the provider cut, usually it's low transverse incision. Just because we're going to assess for signs of bleeding or infection, we want to make sure that's closed and there's no complications. But one thing that definitely will suggest is getting up. Ambulating is one of the best things. Sometimes patients will have increased gas or abdominal distension. They feel extra bloated is one way that they explain it. Sometimes they might have like gas bubbles in their shoulders that accumulate. I think that's one of the harder parts about the recovery post-op.
Exactly, it is, yeah.
So definitely get up, walk around, drink fluids. Ginger tea really helps if that's just my personal suggestion. And then to answer your other question about if you can breastfeed, absolutely. You can breastfeed skid to skid in the first hour, you could do it in the OR. So don't let that discourage you from exclusively breastfeeding.
Yeah, we try to get those babies right there on their birthing parents' chests as early as possible. And
Yeah.
yes, sometimes in the OR. So there's nothing that would be contraindicative
Mhm.
of breastfeeding with C-section,
Yeah.
including meds that you might be on,
Yep.
like a pain medicine or anything.
Yeah.
Well,
Totally.
good luck to you, Harper. Now, Elizabeth, awesome name. Elizabeth from Albuquerque, New Mexico. She had a vaginal delivery 2 weeks ago, and the doctor said I was a postpartum hemorrhage.
Okay.
For some reason, I do not remember everything that happened. I do, however, remember there being a lot of people in the room and the nurses pushing on my stomach and giving me lots of medications. Can you help me understand what could have caused the hemorrhage and what the nurses were doing?
Yeah. So
That's a great question. Elizabeth, I'm sorry for your trouble. That must have been traumatic, especially not really feeling like you remember it all as an active participant.
yeah. Um, So you probably don't remember part of it. It does happen. A lot of times these patients, when they're hemorrhaging, it's common for a patient to say they feel lightheaded, dizzy. You'll often see like low blood pressure. Sometimes their heart rate is really fast as well. So we know that it's tachycardia. And that's common. And what's happening, you're losing a lot of that blood, and sometimes that uterus is boggy, it's soft. And that's what we're checking for as nurses. So when you said you felt a lot of pressure on your abdomen, those nurses were probably massaging your fundus. It's our go-to intervention during a postpartum hemorrhage. So we see that a lot. And one of the reasons why this sometimes happens is uterine atony. Sometimes it's related to tone. There are other things that can cause a postpartum hemorrhage. So sometimes it's tissue issues with like the placenta. Sometimes if there's like traction where the provider pulls on the placenta before it's ready to be delivered, sometimes that could also lead to a postpartum hemorrhage. Sometimes it's thrombin disorders if you have like a coagulation disorder of some sort. And sometimes it's from like tissue trauma, whereas you had a laceration, an episiotomy, something like that. So
Well, you're saying a hemorrhage. Exactly how much bleeding is considered a hemorrhage?
yeah, so when we quantify blood loss, so we're measuring your blood loss, usually for vaginal delivery, anything above 500 mLs, and then anything above 1,000 mLs for a C-section can be quantified as a postpartum hemorrhage.
All right, that's good to know.
Yeah.
That's good. What kind of things can we do? You mentioned massaging the
Yeah, so
fundus.
massaging the fundus. So that's probably why you felt so much pressure. Sometimes too, some of the nurses will empty your bladder. They can straight cap a patient in case that's why, like you got a lot of fluids. Maybe that's why your bladder might be displacing the uterus if that's the reason. And then there's some medications we give. Sometimes we up your Pitocin. You'll get Pitocin postpartum, a medication we usually give to contract that uterus. And
We call that we don't we uterotonics.
uterotonics, yeah, it's a fancy word. We know that uterotonics. So our most common ones are going to be Pitocin, love hormone. Your body makes it naturally. We just give you a lot of it to keep that uterus contracting now that the baby's born. And then other things you might do is Methergen, as long as you don't have elevated blood pressure, or even Hemabate, as long as you're not an asthmatic. And those are IM injections. So those might have been some of the medications you received. And you can receive all of them at the same time.
Of course, they're probably checking your blood pressure and your pulse and all of this
Yeah.
very frequently as you recover from that postpartum hemorrhage, which is probably some other things they were doing. We have to make sure that you remain safe and hemodynamically stable afterwards. You might have even been a candidate for a blood transfusion.
Yeah. Especially if you got lightheaded, don't remember, chances were your blood pressure was low, your heart rate was sky high. So definitely checking those vitals out.
Yeah, thank you. And I hope you recover well and get the answers that you deserve.
Yes, hope you and the baby are doing well at
yes,
this
good luck.
point.
Good luck to you. Now, this is a great one. Forrest.
It's spelled SSSST. Love it. Very unique.
Forrest. That's Forrest. There it
SD,
is.
but it's Forest. Got it.
I get it now. From Portland, Oregon. Oregon. Excuse me. He says, my wife had a baby 2 weeks ago, and she is very sad and crying all the time. She doesn't seem to have a strong bond with her son. Should I be worried? What can I do? That's a good question.
Yeah.
And I said that we would talk about this, with another question. And this is a perfect opportunity to talk about what's normal and what's not expected. All right. We have this phenomenon called postpartum blues. All right. So usually like from day 2 to day 10. All right. It's kind of, I like to describe it as kind of an extreme PMS where you're laughing and crying at the same time. I know myself. I cried the whole way home from the hospital. It was day 3 after my C-section. I'm not exactly sure why I was crying, but I was crying. It's fatigue, it's hormone shifts. There's a little bit of a letdown feeling, all perfectly common and okay. However, if it pervades and seems to get worse, um, and the new parent is kind of withdrawing, yes, possibly showing signs of minimal to impaired bonding, um, then and it's like 2 weeks and beyond past the delivery, we definitely should consider postpartum depression as what might be going on. And Forrest, your wife sounds like she delivered 2 weeks ago. Um, it very well could be that she's struggling with some postpartum depression. First and foremost, we have to make sure they're safe. So staying with her and reaching out to their provider, to her provider, asking for an appointment.
Yeah. Postpartum depression can go undetected. So
Yeah, it's very easy, it can be hidden.
and you're right at that mark, at that 2-week mark.
A lot of people who are feeling it maybe embarrassed and feeling ashamed that they're feeling that way. If I tell somebody that this is how I'm feeling, they're going to think I'm not a good mother.
Absolutely.
And so that shame and that embarrassment kind of compounds how they're already feeling. So it can easily go undetected and untreated, and it needs treating. It needs treatment, medication, counseling, or a combination of both.
Yep.
For that. Forrest, good luck.
Yeah,
to
and
you and
thank
your
you,
wife.
Forrest, for being a partner that recognizes this and calling in.
Mhm.
That was such a great question. So thank you for
Absolutely.
calling in.
Yes, good luck. Moving on to Janelle from Kansas City, Missouri.
All right.
Oh, Kansas City, Missouri. Interesting. Not Kansas City, Kansas? Is there such a place?
I don't know.
Oh my gosh. Anyways, Kansas City, Missouri. Janelle, I'm sorry, Janelle. She says here she failed her 1 hour glucose tolerance test.
Okay.
And she was diagnosed with gestational diabetes. That's all right. That's all right.
It happens.
She says she's worried about her baby having problems with the blood sugar. What should she know about gestational diabetes?
Okay.
Great question.
Yeah.
Janelle, it's not the end of the world, I'm here to tell you.
It happens in pregnancy. Some people,
It does.
they just have.
It's related to the human placental lactogen, I think it's called. It's actually a hormone that um, puts the person more at a insulin resistant phase for fetal growth. Anyways.
Yeah. So you just have to have your blood sugars monitored throughout the pregnancy.
Mhm.
That's the first thing. Biggest thing is you don't want to have a fasting glucose. So before you eat, when you're fasting, nothing above 90, and then 1 hour after, nothing above 120. Those are pretty much the standards the provider might put you on
Very
to
strict, very
monitor.
tight
Yeah,
control.
but it could be something where it's just managed with diet control, or some patients might need medication. Sometimes there's oral medications we give, like metformin, or sometimes patients might be on insulin throughout the pregnancy.
Mhm.
But you still can progress throughout the pregnancy. Other things too is in terms of baby, when it comes time for delivery, we're just going to monitor the baby for hypoglycemia, where their blood sugars are just low. So a baby will need to have blood sugar checks, totally normal. We're also going to assess for like poor feeds, poor weight gain. Sometimes they have signs of like they might be jittery, have some tremors. And so that's what we're looking for as nurses. It could be a scary thing, but hypoglycemia, we can manage it. You can still breastfeed exclusively. Sometimes, if the levels do drop, sometimes we might consider supplemental formula or glucose gel. But the biggest thing is we want to make sure that we're managing it well and that the infant's levels are stable enough. Just because hypoglycemia, if it goes untreated, it can lead to neurological damage and
Oh,
seizures.
yeah.
Sometimes we see, so that's why we want to make sure that we are monitoring the baby before every feed and checking those blood sugars.
So basically, I say that the babies are not diabetic,
Yeah.
and if they're used to getting sweet blood, in other words, their mothers are diabetic, and maybe not, you know, there's extra glucose in the sugar that in the blood that they're getting. These babies are born in what we call a hyperinsulin state. And so you think their blood sugars would be high, but no, they're not, because once they get cut off from their sweet blood dealer, they're still in that hyperinsulin state for at least 12 hours. So that's why we would expect that their blood sugar actually goes down a little, so that's what we're looking for is because babies aren't born diabetic. Um, so
Yeah,
so
so
that's
they'll be
why we're
monitored
checking.
pretty frequently, the first 24 hours especially.
It's really important to know that even if you're feeling okay, to try to keep those blood sugars within the range
Yeah.
that your provider has kind of set, because it means that the overall health of you and your baby and your pregnancy is going to be, have a better chance of being, intact, as opposed to having sugars kind of all over the place. Definitely. Now, Maya from Boulder, Colorado, she says, I'm due with my first child in a month. Oh, it's going to be quite a month for you, Maya, right as we enter the holiday season. I'm not sure if I want to breastfeed or formula feed.
Okay.
How will I know I'm making enough breast milk for my baby? Will I be a bad mom if I do both? Good question. And a question that new parents everywhere struggle with.
Yeah. So, Maya, I just want to say, no, you will not be a bad parent. That's the first thing I want to say.
Mhm.
Fed is best. So, whichever way you choose to feed your infant is totally fine.
Happy, healthy
Breastfeeding,
mother feeding a happy, healthy
formula
baby.
feeding, even if you do one over the other, it's totally fine.
Mhm.
Yes, breast milk has a lot of benefits. It provides passive immunity. We know that, but there's absolutely nothing wrong should you choose to formula feed. So that's the first thing I want to say, or do both. Okay. What I will say is if you are doing both, so breastfeeding is usually every 2 to 3 hours is when we recommend a woman to breastfeed her child. Formula feeding is every 3 to 4, just keeping them on a schedule, maybe every 3 hours, give or take, every 2 to 4 hours, depending on what they had and the last time they fed is what I would recommend. But in terms of how do you know your infant's getting enough if you're breastfeeding? This is a common question. So many moms have. I have yet to meet a woman who doesn't worry about like, how do I know they're getting enough milk? Well, one thing is keep that baby on breast for at least like 15 to 30 minutes. But also we're going to be checking for weight gain. So we weigh the baby every 24 hours. So that's a good indicator that the baby is, eating enough. We expect some weight loss in the first few days after delivery, but no more than 10%. So that's something we're tracking. Also, how many wet diapers they make. So
What goes in must come out.
yeah, so usually by the time they're a week old, they should have 6 to 10 diapers a day. And so that's a good indicator too. Like they're getting enough,
That's a very good point.
right?
Read up on it. You have a month. And you know what? You must make a decision and then change your mind, and that's okay too.
And that's okay.
The nurses are there to help carry out your decisions. So they may make sure that you have all the information you need to make the right decision. So seek their information. Everyone has their opinions, so.
Yeah, and there's tons of resources, lactation support out there too for women in the community. So definitely ask your nurse about that.
Absolutely. Now, Kayla from Washington, D.C., the nurse gave me a shot after delivery because my daughter's blood type and mine do not match. I remember getting the shot at 28 weeks pregnant. So why did I need to get it again?
Okay.
Great question. 5 magic bonus points for anyone who could tell me what that shot was.
Am I not supposed to say it? Awkward.
I guess
So
you could
say someone got Rogan
Uh-huh.
as the shot, is what I imagine.
5 magic bonus points to you.
So typically we give that to moms whose blood type has their RH factor is negative. So with your blood type, you usually have a letter and then like negative or positive sign. So any woman with that negative sign, okay, their RH factor is negative, they need to get that RhoGAM shot at 28 weeks. Then after delivery, we're going to check baby's blood type in case the baby has a positive RH factor. And that's probably what they mean when they told you that you and your baby's blood type do not match. And so usually we will give RhoGAM within 72 hours.
Okay.
So it's only if you had a positive infant and you were negative.
So this RhoGAM basically tricks your body into thinking it has the antibodies. So Rh positive is the antigen. You do not have the antigen because you are Rh negative. But if a little bit of your baby's blood gets mixed in with yours, it's seen as an invader. The antigen is seen as an invader that you need to create antibodies for to get rid of. So the RhoGAM gets on board and your body says, oh, I don't need to make my own. I already have it. And so it prevents your body from creating those antibodies to destroy the invader of the Rh positive antigen.
Which can cause issues in future pregnancies should you have a fetus that is Rh positive blood type.
And you have the antibody running around your system that's already there ready to destroy the blood.
Yeah, and it could even lead to like complications with like fetal anemia and stuff in infants when they're born to a mom with Rh negative blood type. So especially if they don't get that RhoGAM. So we want to prevent any of those complications in the future.
Pretty important to do that. Yeah, it doesn't necessarily affect the current pregnancy, but if you didn't get the shot and you needed it and you created those antibodies, the next pregnancy could be affected.
Yeah.
Good luck to you. Now, Talia, or Talia, I'm not sure how you pronounce it. I'll say Talia from Honolulu, Hawaii. All the way from Honolulu, Hawaii. I'm impressed that we have listeners.
Aloha.
Aloha to you is right. When my son was born at 36 weeks, the nurses kept assessing him for signs of respiratory distress. He ended up being fine, but can you explain what they were looking for?
Yeah, so they were assessing for signs of respiratory distress, probably one of the more common things. 36 weeks is considered late preterm. And so sometimes we'll see respiratory distress syndrome. Usually that's something that's just you'll see really in neonates, especially our premature infants. So that's probably what they were assessing for. We assess for respiratory distress in all our infants. And so some of the common things we look for is if they're breathing really fast. So if they're
Each breath is not adequate, so they have to breathe a lot.
Yeah. And sometimes too, like what we see is like nasal flaring or grunting.
They're working really hard.
And yeah, making sure that they're not like turning blue or purple. So we know that a cyanosis. So we're just making sure that like it fits the picture and also for how many hours old they are. Sometimes you'll see the transient tachypnea, which is when the infants right after delivery, their respirations might be a little bit more faster than we expect. So normal respiratory rate for an infant is 30 to 60. And so if they're a little bit faster, say they're 70, but they were just born 30 minutes ago, I'm not going to worry about that. That's okay, right? Because they're fresh from delivery, they're getting used to this world. But if it continues, that would be something where I'd be worried. And so that's probably why they were monitoring your baby more frequently.
Oh, yeah. And with transient tachypnea, we're looking at the whole picture, right? So the baby was just born an hour ago, having periods of tachypnea or, up to, 70 or whatever. But are they doing okay? Are there any other signs of respiratory distress? The grunting, the nasal flaring, the retractions? Is there anything else to indicate this baby's having trouble? If not, then you can kind of call it this transient tachypnea. Sometimes if it goes on, even if it is normal, oftentimes these babies, we do kind of work them up for, um, if there's any trouble, maybe just a chest x-ray or something like that, just to make sure they're fine because we don't want it to be respiratory distress syndrome by all means.
I'm glad your baby did well.
I know, absolutely. Now, Meredith from Tampa, Florida, she had a vaginal delivery, and the doctor had to use a vacuum suction to help get the baby out. Why were the nurses checking my baby's head so frequently after delivery?
Good question.
That's a good question.
Meredith, so in general, nurses recheck every baby's head just so you know we're looking at the shape, we're looking for molding or any swelling. Sometimes too, we are you taking a picture, okay? Awkward. Okay, I didn't give consent for that.
That was bad. This might be real.
All right. But we're checking for their head shape. We're also checking their fontanelles. Babies have two, interior and posterior fontanelles. They're the baby's soft spots. They should be soft and flat. If they're sunken, that could be concerned for dehydration. And if they're bulging, that could indicate we might have a bleed, which is probably also what they were looking for because you had a vacuum assisted delivery.
So a suction cup got put on your baby's head like a big old hickey.
Yeah.
So maybe they were looking for a cephalohematoma.
Yep. Or even like any form of like intracranial hemorrhage. That's usually what we're looking for. So that's why we assess the head more frequently. We do measurements of the head circumference as well to see that there's not a lot of increase in swelling and increase in size. So it's all part normal, but that's
Just
what we're checking
for the just in case.
Yeah.
Because the baby can't tell us, man, do I have a right? They can't tell us. So we have to go. It can be very subtle. So
Make
we
our
have to
jobs easier if they could.
Yeah, they sure would. Well, maybe.
Hmm.
I can imagine the whininess. All right. Now on to our listener from Philadelphia, Pennsylvania, Mira. My baby is being monitored for sepsis because I had chorioamnionitis. I was in labor for 26 hours after my water broke. I was treated for GBS, whatever that is, with penicillin during labor. So how did they know I had an infection of the amniotic sac?
Good question. So GBS is something separate. I'm imagining you're talking about group beta strep. So being treated in labor for that, with penicillin is totally normal. That's usually just some perineal bacteria. We usually treat women with that. Chorio, on the other hand, that's an infection of the amniotic sac, sometimes the fluid. And so sometimes what we will see is moms will develop a temperature. So they'll be like febrile, like elevated temperature, and pretty quickly too, especially if their their membranes were broken for a long period of time. Especially as you approach that 24-hour mark, which I'm pretty sure you said you were ruptured
28 hours.
28. Okay.
26.
26. Okay. So you were ruptured for a long period of time. And as you approach that 24-hour mark, you're at increased risk of having that
Anything from
infection.
the outside going in because your womb is open.
Yeah, and we try to not put so many things in. So we try to decrease the amount of vaginal exams. We don't do vaginal exams too once a woman's ruptured if she really needs it, or there's concern. Otherwise, we don't even do that. So we don't want to introduce any bacteria in there. And so besides the fever, sometimes moms will be tachycardic, so their heart rate will be really fast. Sometimes we even notice that the baby's heart rate is fast too. We'll notice fetal tachycardia, which is why we're monitoring the fetal heart rate so frequently. And then the other thing too is sometimes there's a certain odor that we'll notice as amniotic fluid continues to leak and throughout the labor process.
Definitely, it definitely has a foul smell to it.
Yeah, so chances are you probably experienced some form of those symptoms, and that's how they knew you had choreo. and why they're monitoring the baby more frequently.
Yeah, we don't want the baby to also become septic. In fact, if we're saying mom had choreo, we're just assuming baby is infected as well, and very well might put baby on antibiotics at the same time.
Mhm. Yeah.
Jenny from Rapid City, South Dakota. I had a C-section for cord prolapse. Ooh, in a weird position. They had me on my back with head down and lower than my feet.
Okay.
Why did they do that?
So I imagine what you're talking about is the Trendelenburg position. So
Yeah.
typically that's what we do as nurses. We with the cord prolapse, so we don't want the presenting part of the fetus to come down and put pressure, compress that cord, because again, that's that baby's lifeline. We've mentioned this multiple times throughout this podcast. And so one thing we do as nurses, we try to alleviate some of that pressure. One thing we can do is Trendelenburg. So bringing your head down.
Using gravity.
Yeah, at a position where your head is lower than your feet, we try to do that to help alleviate or prevent some of that compression on the cord.
Yeah. Whoever found the cord prolapse might also be with a sterile glove trying to push the head or whatever the presenting part up off the cord
Yes.
from your vagina also.
Yeah.
So it might be a kind of a weird ride down to the OR because that's the only method of delivery we recommend with a cord prolapse is a C-section. So we put you in that Trendelenburg position and have somebody in there pressing on up off the cord, basically, not touching the cord, but pressing the presenting part up off the cord.
Yeah. So I'm hoping though, since you're calling in, everything went well.
I hope so as well. Good luck to you, Jenny. Now, Alex from El Paso, Texas. El Paso, Texas. Oh, I like this one, Alex. I just graduated from nursing school and I will be starting a job in a newborn nursery at the local hospital. Good for you, Alex. What are some key things I should keep in mind in terms of what is normal newborn findings and what are concerning newborn findings?
Okay. Well, let's start off with like the bad. All right. Let's just get bad out of the way so we end on good. Okay. So
All right.
concerning things, I would say respiratory distress. I mentioned this to a previous caller. So nasal flaring, cyanosis. Acrocyanosis is normal where you have like bluish purple tints of like the
Hands,
peripheral
hands,
terms. Yeah.
feet. Okay.
So hands and
That's
feet.
called acrocyanosis.
Acrocyanosis, good.
Hands and feet,
Normal.
but
Cyanosis,
not circummoral cyanosis.
Yeah.
None of that. We don't want that.
yeah. Lips,
Right.
chest blue, no. Right, that'd be a concern. Also like any infant that's like super jittery, poor feeds, not gaining weight, those would be things that I'd be worried about as well. And then
We check vital signs all the time to know
Yes.
newborns. So
Yeah.
the normal ranges of vital signs.
Yeah, 30 to 60 for respiration, 110, 120 to 160 for heart rate, and then temperature, nothing below 97.7 is what I would say, degrees
Yeah.
Fahrenheit. Babies, they have really poor thermal regulation, and so they can overheat, but they also can lose heat really easily. And so any temperature below that 97.7 mark puts them at risk of hypothermia, and then they use too much energy, they exhaust their calories, and it could just lead to hypoglycemia. So everything ties in. So that would be something else I would.
And you know what I have to mention when you mention hypothermia? And I don't mean to interrupt your flow, but some babies who are actually infected don't get a fever. They actually drop their temp.
That's true.
Those newborns, tricky little ones they are.
Especially for sepsis. That's probably one of the first things I see. It's respiratory distress and then low temp.
Low temp, not a fever, but a low temp. They're quite sick at that point when they can't maintain their temp.
Yeah.
We should, and I don't mean to get off on this tangent,
No,
but as the nurse caring for a newborn, we should provide that thermal neutral environment or neutral thermal environment, I guess is probably more the way to put it. In other words, allow them to kind of figure it out, but don't either give them too much heat or not enough heat. So that neutral thermal environment can just kind of take the pressure off them, that they won't have to work so hard. They're just figuring out how to keep themselves at the right temperature without undue stress in either direction.
Yeah. Some other things I think that are really important is ABCs of sleep, safe sleep.
Mm.
Infants should sleep alone on their back, in a safe place, in a bassinet or crib, nice firm mattress. And then sometimes people will ask, can I keep a bulb syringe at the bedside? I say it's fine, give or take, especially if you have a baby that gags a lot, spits up a lot. I like to know where my bulb syringe is, so that's one advice I will always say to anyone starting off in the nursery. Know that bulb syringe, have it open and ready to go. Sometimes infants, as they're learning to feed, or they have a lot of amniotic fluid, sometimes they'll be gagging, they'll turn purple, they'll be spitting up, they can't get it out. And so having that bulb syringe there to like help suction out that mouth and their nose is definitely something I'd recommend
Mhm.
as well.
Absolutely.
Yeah. What else?
Um,
Talk about some normal stuff.
yeah, let's talk about that.
Mm.
You know, a healthy baby will have no matter what their ethnic origin is, they will have that pink undertone to their
Yeah.
skin. If you blanch their skin, you can see a pink undertone to their
Yeah.
skin.
Baby skins are funny. There's so many like newborn like skin findings that you'll
Hmm.
see, which are all normal, but like we as adults don't have.
Right.
Um,
Um, Mongolian spot.
Mongolian spots, yeah, like that blue, purple color. A lot of times I see that in like the lower back, the buttocks area.
Yeah, it looks like a bruise, to be
Yeah.
honest with you. It's so very important to document it that
Yes.
you found it. Not because there's any clinical significance to it, but we don't want it to be mistaken for a
A
bruise.
bruise for
Us,
abuse.
yeah, and particularly like when they go off to their pediatrician's office 2 weeks later, and it appears that they have bruising on their buttocks.
Hmm.
A prudent provider will go back to the admission assessment and see, oh, it's a Mongolian spot.
Yeah.
It's been there since birth. It's not a bruise.
Mhm.
And move forward without a DCF referral. Otherwise, how can we say? Because it very much looks like a bruise.
Yeah.
Other newborn skin,
Milia on the nose, the
oh
main
yeah,
spots on the
the
nose is Milia.
sebaceous, exposed
Lanugo,
sebaceous
the
gland.
peach fuzz.
Oh
Sometimes on like the
yeah.
backs, the forehead. It's like they have a unibrow.
Yeah, my some the hair is light colored, but in my family, and
I know.
probably not your family.
I'm well aware. My kids,
My beautiful niece had quite a bit of lanugo, but it was dark hair.
yeah, they're
Yeah,
hairy babies.
hairy
But it's,
baby.
yeah, it's
Yeah,
normal. And sometimes too, they have like the newborn rash.
yeah, that looks like flea bites.
Mm,
Ah, yeah, erythema toxicum,
yeah,
another Harry
weird
Potter
name.
spell. Yes,
Terrible
erythema
names for
toxicum.
something that's totally normal and most babies get.
Yeah, it looks like a little flea
Face,
bite.
trunk, yeah,
Yeah.
little red dots. That's totally normal.
Mm-hmm. Wow.
But yeah.
Um, and then, you get the yellowish tint. So pink undertone is normal. There is a little bit of jaundice that might happen, but we just don't know, right? It's very subjective, the color jaundice, especially with our varied skin colored babies. So, checking the bilirubin level would be important.
Yeah.
Some places do serum bilirubin. Some start with the transcutaneous the skin probe, the light test, the light meter, if you will. And based on what that is, may have to go and do a serum bilirubin. The serum bilirubin is the most accurate because we don't want that bilirubin level to get too high.
Yeah, we definitely want to catch that earlier because
Mhm.
sometimes we have to start these infants on phototherapy, these
Yeah.
like little blue light tanning beds.
Mhm.
And so we want to catch that earlier. So I think most hospitals are protocols to check the bilirubin level every few hours,
Mhm.
but don't feel like you have to wait. If you notice the baby is looks a little bit yellow, it's better to be safe than sorry. Get that serum Billy if needed.
Yeah. And the other thing we can't take for granted, and I can say this because I'm old and I've been in the business a long time.
Only
Back
35
when,
years.
huh?
Only 35 years.
35,
You have that.
35-ish. Um, Back then, they said newborns didn't have pain. Uh, and we as nurses knew they were having pain.
Yeah.
But so now we do definitely acknowledge that our newborns have pain. In fact, we have a newborn and infant pain scale, the NIPS, um, that we can objectively kind of measure their pain. Because again, they can't say, I'm having 6 out of 10 pain when we ask them. You can ask as many times as you want. They're not going to tell you.
And I think that's important to tie in when you do vitals, like assess your newborn's pain. Don't forget about that. Like, yes, babies communicate by crying, but it's different. There's so many things we can do.
Yeah. Well, tell me about those things.
Well, you could do skin to skin if the parents are open to it. Like they love that, especially
Mhm.
maybe with mom, dad, anyone who's willing to do it really skin to skin. Do it as a nurse. No, I'm just kidding. Don't do that. That's
No.
awkward. But the parents definitely encourage skin to skin. Also, swaddling them is probably the best thing you can do. They love to be nice and snug. So swaddle them up, fetal position. Other things too, sucrose. Have you ever used sucrose?
Yeah, every time that we do a painful
Yeah.
procedure.
Yeah, so sometimes people think like sucrose is a pharmacological management, but that's actually non-pharm. It's pretty much sugar water. Like that's all it is. And it
20%
just
or 40%, whatever it is.
yeah.
It's not very
It's
sweet.
not much, but we call it like sucrose or like sweeties. You might hear it as, but yeah, it's just something too we can do, especially for a procedure like circumcision, blood work, anything like that.
And then just sucking can provide
Pacifiers.
that
If parents are okay with it. That's the
yeah,
other thing I'm going to say.
absolutely.
Never give an infant a pacifier without asking the parents because some parents are like absolutely against pacifiers. So always get their permission.
Mm-hmm. I think you're going to be in good shape, Alex.
Yeah.
Good luck to you.
Follow our tips. Call us if you need any help.
Absolutely.
Not after 9 p.m.
No, gosh, no. But I do look forward to hearing about your success in the future as a newborn nurse. This is a great question. This is from Anonymous.
Is that their name? Anonymous?
That's the name they're giving us.
Maybe that is their name. I'm not here to judge. I've heard every name. Jakipna, SD Forest, whatever you need.
Anonymous from New Haven, Connecticut. I am a nursing student in your class.
Probably yours.
Well, who knows? And I was hoping you could break down all the G's and P's of OB that you have covered throughout the semester, like G TPAL, GA, P's of labor. If you have time, can you also discuss the stages of labor?
Yeah, it has to be in your class.
Oh.
My students know all this.
I see.
Yeah.
So now she's questioning
Mine are prepared.
my integrity as a professor. That's good. That's good.
Okay. I trust my students, so they're really a great crew.
I'd like to, we don't have time, and I feel like that was a bit of a challenge. If we had one more week in class, I'd open that gosh darn wall between our classes and we would show them.
I have faith in my crew.
We would show them who knew more.
I'd bring the tissues for yours.
Oh, those are fighting words. Anyways, Anonymous.
Everyone.
Professor Lopes, being the superior teacher, can explain that while I have a sip of my soda.
All right. GTPAL. Gravida. So number of pregnancies, including the current one is what I thought.
Oh, good. Yep.
Right. Then you have your T is your term. So term pregnancies after 37 weeks. Your P is term less than 37 weeks.
Okay.
And then your A
above 20. So between 20 and 37 weeks.
Yep.
All right.
And then your A is any abortion termination of pregnancy.
Any pregnancy that ended before 20 weeks.
20 weeks, yeah, because a stillbirth is usually after 20 weeks.
Depends on the gestation.
Yeah.
So yeah, stillbirth would be a P, unfortunately, probably with no L.
Correct. And then L is living children. So how many currently living children? And then you have GA, that's gestational age. So like how many weeks pregnant a woman is.
How many weeks is a normal pregnancy?
40 weeks. That's how we get your due date. EDD.
EDD, estimated due date. Estimated.
Estimated due date. Yeah, that's where you could use, what is it? Is it
Nagel's rule.
Nagel's rule based on the first day of the menstrual cycle, plus 7, add a year, math.
Subtract 3.
Yeah, at some point you get the date you're due.
No, your Nagel's rule.
Yeah. And then we mentioned this, greater than 37 weeks is term, less than 37 weeks is preterm. What else? P's of labor.
Yeah.
Passageway is number 1. So where the birth canal. Okay, so here we think about your pelvis, um, adequate pelvis, gynecoid.
The gynecoid pelvis, yeah.
This is the ideal
Opening
one.
is-
That's the goal. That's the
Yeah.
A. That's the one you want. The
Mhm.
one you don't want is the platyploid.
Platyploid, yeah.
Platypus. That's how I remember it. A beak like the platypus, flat. Terrible pelvis to try to push the
Yeah,
baby out.
yeah, it's
You're
most
gonna have
likely
a
not gonna
C-section.
fit. It's most likely not gonna
That's
fit.
it.
That just because you have a gynecoid pelvis doesn't mean it's shaped the right
Doesn't
way,
mean
but it
anything.
still might be too small for the baby's head.
Yeah, that's where you got to look at your passenger. That's another
All
P.
right.
Baby and placenta, another P of labor. I don't know if you're looking for that. Not a labor, not one of the P's of labor, but
Mm-mm.
definitely a P related to OB.
So the passenger's next. Passageway, passenger.
Yeah, so you got to look at like where the baby sits, what position is on, like are they breech, are they vertex, head down, are they flex, extended? So a lot of that goes into it. Then you have power.
Oh, the power.
It's just contractions, that's all it is.
Contractions and pushing when you
Yeah.
get to that phase.
And
Yeah.
then we have position, usually maternal position. One thing I do like to add too is if you ever have an OP baby, so the back of their head is
Occiput
facing
posterior.
the back of mom's body, okay? So like that baby's like sunny side up. If that happens, hand and knee position. Number one rec I could tell you if any of you ever go into L&D, put your mom in hands and knees if she's able to get that baby to turn. Ideal position to push out a baby is OA.
Occiput, the back of the baby's head facing the front of the birthing parent's
Yeah.
pelvis.
Yep. And then we have your psychological aspect, which is really offering your mom that support, encouraging her.
And information. I mean, I think ignorance breeds fear. Fear breeds anxiety. Anxiety breeds tight, tense muscles. And I have seen patients too scared to progress in labor.
It's exhausting having a baby. And
Mhm.
so they need you as their nurse to help encourage them. Everyone in that room, encourage them, support them mom in any way we can.
Mhm.
Let her know she can keep going.
Absolutely.
Yeah.
Now, the stages of labor, this anonymous from New Haven wanted us to review real quick.
Okay.
There's 4 stages of labor.
Yeah.
I'm gonna
You can take
blurt
over.
it out. No, I'm gonna
Oh.
blurt it out. And you can go on. The first stage of labor, that is the labor, in my opinion. That is the hardest, least glamorous part of this whole
Yeah,
thing.
that's the longest part.
Yeah,
Dilation.
it's called dilation.
Dilation, yeah. So getting that cervix to dilate, open up, and then now we call that effacement.
It's a lot of work, and it's generally the
It's a lot.
longest period of time.
Yeah. Latent
in the
phase
whole
takes the
process.
longest.
All right, so this first stage is broken up into a couple of phases.
Yeah.
The
So
latent phase.
latent phase is usually
Birth
getting up,
phase.
reaching that 6 centimeters dilation. So like 0 to 5, 6 even. Could be because like you want to get that cervix to start opening up, but that takes a really long time. Once you get like 6 to 10 centimeters, the goal is 10 centimeters, you're in active phase. Okay, that's one thing we see. In latent phase 2, contractions usually are only like every 5 to 10 minutes, if that. So there's no good frequency, whereas in active phase, you have contractions every 2 to 4 minutes, so they're more regular.
So contractions get longer, stronger, and closer together the farther along you go.
Yeah.
From latent phase to active
Yeah.
phase.
And in terms of your cervix thinning out, so the effacement, usually like up to maybe 40%, like that's usually the early phase because your cervix is pretty thick. And so it starts to thin out in the early phase, but once you're in that active phase, you're getting like the 60 to 100%, right? That's a good indication you're in active labor.
Well, that makes sense. The second stage you call expulsion.
Yeah.
It's a fancy word for
push that baby out.
Yeah.
What's it? Push that baby out.
So it's
Take
a whole
the
pushing
wide.
phase from
Okay.
when you start pushing to when the baby
Yeah.
is delivered.
Takes mom some time, but the goal is to get that baby out. See the crown.
See the crown.
That vagina makes a crown.
Woof.
Yeah.
Yeah. So that's the second stage.
Mm-hmm.
And then is it over?
No.
Oh, it is not.
Remember, you
In
have
fact,
2
it's only-
passengers.
Oh,
You got
Okay.
your baby, your fetus, and then you have your placentas.
All right, so the third stage is the placental
Yeah.
phase.
So it's
All
got to
right.
separate and then it's got to be delivered.
All
So
right, so from the delivery of the
baby's out.
baby's out, and then we wait for the delivery of the placenta. It can take up to half an hour.
Half hour. So keep
Yeah.
that in mind.
Yeah.
You sometimes get impatient providers that like to
Tug,
pull.
tug.
And then that could lead to a hemorrhage from
Right, we
traction.
do not want that. So you can see a little tenting of the abdomen. If they're paying attention, they might go, "Ooh, what's that?" Um, we'll have a gush of like dark blood, and you can see the lengthening of the umbilical cord out of the vagina.
Yeah.
And that is kind of the indications that the placenta is separating and coming out.
Yeah.
We definitely, ideally, wait for that before helping it along out. And then, so then is it over?
No, then you have
No.
sort of, but no, the baby's out. People think it's over, but no, then the restorative.
So
Postpartum phase
stage
starts.
fourth stage is that the initial recovery
Yeah.
in the postpartum phase. So restorative.
Yeah, so you start your postpartum phase. You know what your nurses are gonna do?
Poke,
Push that
poke.
buttonage. Check
They
that
will not
buttonage.
leave you alone. On top of
Check it briefly.
and on top of like taking vital signs, looking at the bleeding, poking at the belly, massaging the fundus, initiating bonding, helping with breastfeeding, getting you up to the bathroom perhaps at some point, making sure your recovery. It's very close. I mean, postpartum hemorrhage is our main concern. We're monitoring for and trying to prevent in that fourth stage of labor.
Yeah.
So we're not gonna leave you alone. I'm not going to
Sure.
leave you alone. I want to finish off with two very special listeners, as they all are to us. Amina from Dearborn, Michigan. She says she's being admitted for cervical ripening.
Okay.
Yeah. And Pitocin induction. What should I expect? Will the contractions be painful? What will my pain management options be? That's a loaded question, Amina. We look forward to hearing about your recovery afterwards.
Yeah. So cervical ripening. So we've got to soften up that cervix before they start Pitocin. That's expected.
increase that
Sometimes they
fitness
use
score.
miso. Is one of the more common ones. Cervidil. There's different things they might use, and then they'll start you on Pitocin. Hopefully, if you your cervix is soft enough.
We say ripe enough.
Yeah. So that's pretty much what you can expect. They'll do the medications. Your nurses will be monitoring how the baby tolerates these medications and also how often your contractions are. The goal is to get you to contractions that are every 2 to 3 minutes, but not more than 5 contractions in a 10-minute period is usually what we say. We know that as tachysystole, which is probably the biggest thing we're looking for when we're giving you
Want to make sure we're not giving it too
to
much.
induce or augment labor. Yeah. And if that happens, there are things we can do. If you're on Pitocin, usually we just stop the Pitocin. But if you have a medication, not every medication goes through the IV. Pitocin is, so that's one of the things we can just turn it off. But there are medications we can give. Say you received a medication that's a vaginal insert, rectal insert. There's different things that the providers will give. Sometimes we can't just take those out, especially if they've dissolved already or given you the medication. But there are medications we do, like tocolytics is what we call them. So you might hear the nurse giving we have nifedipine, we have terbutaline, a lot of enes, and then you have mag sulfate. Usually that's more of like preterm labor, but if you're going to have tachysystole related to induction or augmentation, usually it's going to be terbutaline or nifedipine that the nurse
They're going to give it to you to try to slow those contractions down.
Yeah.
Because everyone has to rest, both the birthing parent as well as that baby, right? We need the uterus to relax and allow for blood flow and oxygenation. If it's nice and contracted like that, there's not good blood flow to the placenta. So both the baby and the birthing parent need that rest in between. So tocolytics, that's a fancy word. That we might have those nearby in the event that those contractions get to be too frequent, too strong. It's a balance. We want you to have those powers of labor, right? To progress in labor, but not too frequent.
Yeah.
And then pain management. There's a lot of different things your nurses and providers can offer. There's non-pharmacological stuff. A lot of people find getting into the shower is helpful, getting up and moving around, massage, guided imagery,
Yeah.
some nice practice breathing techniques, um, that sort of thing. And then there's things like
Anesthesia. Some people go straight for the
oh
epidural.
my gosh, there's definitely some people who
They
want
walk in, I'm
the
1 centimeter
epidural.
dilated. Can I have the epidural?
I don't blame them. The epidural is it's
I have
sometimes
one
scary to think
contraction
about,
every hour.
but can really make a difference
Yeah, so
physically.
epidural,
Yeah.
anesthesia, and then some people don't want the anesthesia like that. Some people pick medications. So you can get medications through the IV or even inhalation. So nitrous oxide, something else patients can get, or IV fentanyl or Stadol I've given as well. Those are two really common medications.
Yeah. The thing about the IV fentanyl or Stadol, any medication we give systemically does cross the placenta and go to baby.
Yes.
So we just have to be mindful of the timing on that. And I know we talked about this in previous podcasts, but if we give that medication to the birthing parent and they are feeling fine, so relaxed and ready to go, and all of a sudden the baby's born like within an hour of that, um, the baby might be at its peak medication just when we're needing them to breathe on their own.
Yeah.
So having a resuscitative effort, so a resuscitation team um, available, immediately available, to kind of assist that baby in breathing, which they might not want to do on their own initially because they are kind of drugged up.
Yeah,
So we
be
just have to be
prepared
careful. We
for
just have to be
them.
careful with those systemic meds.
Especially if it was within the last like 30 minutes, like you
Yeah.
have to watch for that. Like these kids come out blue
Yeah, they don't like breathing.
or
They don't want-
respiratory effort, so you
Yeah.
gotta assess
I've
their
given them a little bit of
really
Narcan.
closely. Yeah.
Yeah. To get, and that's
So
perfectly
keep that in
reasonable.
mind.
Yeah. Good luck to you, Amina.
Yeah.
I know that you will be kept
May you be
safe.
comfortable
May you be comfortable.
and have a great, safe delivery.
Absolutely. And finally, Kiana from Anchorage, Alaska. She also is a new grad nurse.
Nice.
Yeah, new grad nurse here.
Excited to
I
hear.
just started working on the L&D floor and am learning how to read fetal heart rate tracings. Any pointers on how to remember what I'm looking at?
Okay.
Veal chop.
Veal chop, number one thing I would say. So when you're placing the transducer, one thing is this was a tip my preceptor had told me, so I'm just going to mention it. So you always want to find where the baby's back is. You could use like the Leopold's maneuver to help locate the back because that's where you're going to auscultate that heart rate best. Yeah, what Libby's doing. But also like no too, like if a baby is head down, usually it's in the lower part of the abdomen, like under the umbilicus. When a baby's breech, so if you find that heart rate above best, like above the umbilicus, that can indicate that the baby's breech. So sometimes
So the heart rate you're gonna find, well, anatomically, because your heart is closer to your head, right?
yeah.
So if it's head down, it's gonna be lower abdomen, head up, possibly.
Yeah, so that's how and babies move all the time. Like I've seen babies, they were vertex one day, the next day they're breech. And so that's how I've discovered some babies are breech. So just in case, that's just something to keep in mind. Sometimes babies act a fool, you know. But let's talk about fetal heart rate stuff, veal chop. So you're gonna look at your baseline first, ideally between 110 to 160 baseline. You look at your variability. The goal's moderate variability. Squiggly lines, okay? And then you're looking for the presence or absence of accelerations in decel. So that's where veal chop comes in. So accelerations are going to be these increase in fetal heart rate from baseline. If your baby's at least 32 weeks, at least 15 beats per minute for above baseline for at least 15 seconds. That's all it takes. And they usually look like these pretty 15. Mountains. Okay. And this is something that's reassuring. Baby's getting enough oxygen. Their central nervous system is functioning. So we love that. That does not require any interventions. And if they're there, great. If they're not, doesn't mean there's something wrong, but accelerations is probably the most reassuring thing you could see. And then for decels, there's three types. There's earlies, lates, and variables. I'm gonna start off with earlies because that's usually a gradual decrease that mirrors the contractions. Those rely on the contractions, and usually the drop from baseline starts with the contraction, and like the peak or the lowest point of that deceleration, the early decel lines up with the peak of the contraction, and then the contraction will recover at the same time as the baby. So those mirror.
So we got contraction going up.
If you end up watching this, you'll see.
Wow.
Right.
So contraction starts to increase, like on the monitor, you see the mountain going up the mountain. And as it's going up the mountain, the fetal heart rate is starting to drop down.
Yeah.
And at the lowest point of the fetal heart rate deceleration is the highest point of the contraction,
Yeah.
is what you're saying.
Yeah.
And as the contraction starts to go away, the heart rate starts going up.
Correct. Yeah.
All right. So it's opposite.
We should make it dance.
I know we should. I don't think I could do that.
Yeah,
I don't
okay.
think I could. Yeah, maybe you could, but
All
not
right, we'll
me.
make it
I'm
dance
too old,
next
but-
time for our next teaching semester, all right?
All right, well, we
Yeah.
can work on interpretive dance
That's it.
as a teaching method.
Perfect.
So those are early D cells.
so
Is that
usually-
terribly indicative of bad things?
Nope. So that one is why I started off with this one. This is also something that you don't have to do any intervention for. Usually we see this with head compression. So as that baby's head is coming down, usually an indicator that that baby is moving down, which is the direction you want it to go.
I sometimes see, that sometimes is what I see, especially if they're comfortable with an epidural and all of a sudden you start seeing early D cells.
Yeah.
They might
They
be
may
ready to push. That
fully
head might be
dilated,
like,
that baby's
that
ready,
head
so-
might be kind of coming down in the
Yeah.
into the
So early is a
passageway
good
quite a
thing.
bit.
So you don't have to do anything.
Early
Probably
is-
means she's progressing, ready to push soon.
Okay.
Yep. And then we have variables and late. So variables can occur with or without contractions. These are usually abrupt drops from that baseline.
They look
and-
like V's or
or
U's.
Yeah, they're
So
pretty abrupt.
abrupt down and then an abrupt return.
Yeah, like that's a variable right there. Peace. All right. So they
is.
will usually occur when there's some form of cord compression.
Mhm.
So sometimes we will have to do an intervention. Most common thing is we're gonna have to reposition mom. Left lateral is our go-to position. But if she's in left lateral, turn her to right lateral. Do something different. We gotta alleviate some of the pressure that's occurring on this cord. And so then the only thing after that is late deceleration. So lates are going to be so similar to earlies where they're gradual drops from baseline, except they are starting after that peak of the contraction. So your contractions already started, and then the baby's like, you know what I should do? Let me start dropping. Let my heart rate drop. I'm a little bit late, but here we go. We're going down. So contractions already started, and now my baby is dropping. As the contractions recovering, that baby is still coming down and then starts to come up only after the contraction is over. So during like that resting period.
So that baby is saying, you know what? I'm trying to be good. I'm trying to be good, but I really don't have enough. I don't have enough oxygen. I'm trying. You know what? I have to drop my heart rate. I have to
Yeah.
drop my heartbeat. So they try to stay good and then they say I can't do it. And that's when they start dropping the heartbeat. So after the peak of a contraction, they say that's it. I need to preserve and drop my heartbeat.
Yeah.
Is that mean the labor's progressing?
Yeah. So that's usually
Mm.
related to like placenta-utero insufficiency. So
It's a baby
something's
who's
going on.
struggling.
Yeah.
We
with
need
the
to do
placenta
something with
uterus.
that.
You have to do something. So change mom's position, IV bolus.
Stop the
Oxygen.
stress. Stop the
If
contraction.
she's on Pitocin, stop the Pitocin, of course. If she's not on any, then reposition mom, IV bolus, oxygen, on rebreather. Call the provider, get help for sure.
Yeah. So intrauterine resuscitation.
Yeah,
All right.
that's what it is. So that's where veal chop comes in. So
V
variable
is for variable, and that means
cord compression,
E is for early, and that means
head compression.
A is for accelerations, and that means
That baby's okay.
okay. And L is for lates.
That's placental uterine insufficiency.
Yeah. So keep that in mind. The ones that we have to do something about are late decelerations and variable decelerations.
Yeah.
Generally change position. That's what.
Yeah. So your first one sort of veal, and your last one late. V and L.
Vienna.
Those two in the middle, they're fine.
All right. It's been an absolute pleasure serving our listeners.
Yeah.
Here in this fall semester. We look forward to many more podcasts, many more times together, talking about what we love. Um, and I don't know about you, but it's been a true pleasure um, um, serving our listeners.
Yes.
And you know what? We might joke a little bit, but
It was
it's been a true
fun.
pleasure spending the time with you as
Yeah,
well.
of course.
Thank you very much. Respect your elders. That's about all it's the only advice I have to give.
Okay, well, I could also tell you be kind to your patients, be considerate of their
Oh,
feelings,
you
any
know, we are guests.
cultural value,
Yeah, we are a
anything that
guest
they have,
and we are a
honor
guest
them.
in their memory. And they will remember you no matter what. Let it be a good memory. And a good memory definitely is somebody who is caring for them, keeping them safe, but also respecting their values and their cultural needs. As we know, culture plays a huge part. There's a lot of rituals that will make people feel safer.
Yeah.
And that they're doing everything to please their gods and their all the myths and legends and beliefs of their culture. Sometimes they fall back on in times of stress and in important moments in a family's life. So being open to learning about them and seeing how we can weave them into the care that we are providing.
Yeah, making it a great labor experience.
Absolutely.
This is a really exciting time in their lives. And so we want to be as supportive of them and honor any of their values and beliefs and any traditions they want to instill in their labor process and at the birth for the birth of their child and as they welcome their child.
Cultural humility is basically keeping in mind that we can never possibly know everything there is to know. And so being willing to ask the question and hear how we can help them carry out that we can learn more about each of our patients. I think will keep you growing as a nurse and as a human being.
Yeah, and don't be afraid to ask questions. Apologize if you happen to make a mistake or miss something. And as nurses, we learn every day. So keep learning as much as you can. It'll make you a better nurse. All right. Good luck to you guys.
Bye.
Bye.